topic. Now, the layers of the thoracic wall. Now, in our previous lecture, we have discussed enough information that you can figure out the layers of the thoracic wall by yourself. So, these layers of the thoracic wall they become important when you are going to when you're going to access the thoracic cavity, when you're going to pass a needle into the chest cavity. So, which layers are there? From the outwards and inwards, there is skin. Then there is superficial fascia. Superficial fascia can be, by the way, divided into superficial fatty layer and followed by membranous layer, also known as fatty layer is known as Kemper layer, and membranous layer is known as Scarpa layer. Membranous layer, Kemper's layer, it's for me, the mnemonic was the fat makes a camp on the top, so it's Kemper's layer. Scrap is on the floor, so it's Scarpa layer. So anything that helps you remember. Now, the next item is tricky. That's why I discussed the topic of extrinsic muscles with you. Now will be the muscle that is the extrinsic muscle. It depends upon through where you are approaching the thoracic cavity that will change the name of the muscle you are going to say. For example, if you are going to insert a needle from the anterior aspect, you are going to insert a needle right here where your mouse cursor is. This is very common place for emergency needle thoracostomy. So at this point you will go through skin, fascia camper scarpa, deep fascia, and then you will go through pectoral muscle, and after that you will go to external intercostal membrane, then internal intercostal muscle, then innermost intercostal muscle, and then fascia of the thoracic, internal thoracic fascia, that is endothoracic fascia, and then parietal pleura. However, if a person it gets tube inserted from this point where my mouse cursor is right now, then you will say skin, two layers of superficial fascia, deep fascia, then serratus anterior, then you will say external intercostal muscle, external intercostal, internal intercostal muscle, innermost intercostal muscle, endothoracic fascia, and that. And even in the back, when talking about that, in addition to serratus anterior, when sometimes when the pleural fluid is drained, then you may be sometimes find yourself going through latissimus dorsi. You may find yourself going through latissimus dorsi right here. So if you are going to access the space from the back, then you will find rather than going to the skin, superficial fascia, deep fascia, you will find your going self going through the latissimus dorsi and then external intercostal muscle, internal intercostal and innermost intercostal. I'll get to your answer. You have asked the question, does needle puncture affect collateral branches? I will get to this answer when we'll discuss intercostal vessels and nerves. So that's the thing that I want you to keep in mind when talking about the layers of the thorax, uh, skin, superficial fascia, deep fascia, and this is the layer that depends upon if any question you have mentioned the point of entry is mentioned like second intercostal space near the midline, then you have to say pectoral muscle. If in the question it is mentioned mid-axillary line, fourth intercostal space, then you have to mention serratus anterior in this point. If you are mentioned in the posterior scapular line in the ninth intercostal space, then you have to mention in the 10th intercostal space, in the 11th intercostal space, sorry, you have to mention latissimus dorsi. Otherwise, most of your questions that are not explicitly asked where the needle is being passed, you just ask the layers, then you are okay to go which one of the muscle you will say that will do work for you. So there is intercostal, internal intercostal, innermost intercostal, endothoracic fascia. This is the yellow in the shown in the yellow here. This is the fascia that will line whole of the thoracic cavity from the inside of the rib cage and costal muscles, from the superior aspect of the diaphragm and the inferior aspect of the thoracic aperture and the suprapleural membrane. So this is the fascia, and then there will be parietal layer of superficial fascia. There will be parietal layer of pleura, and then there will be this pleural space that will be accessed there. So that's what we talked about from margin accessing anteriorly. You are going through pec major and external intercostal membrane. Laterally, you are going through serratus anterior and external intercostal muscle. Posteriorly, you will be going through latissimus dorsi when going through there or there. So these are the few considerations that you have to keep in mind. Now, passing a needle or passing a tube into the chest cavity. When do you need to do that? Sometimes that happens, any injury, it happened from the outside, a person got a trauma, bullet wound injury, or any penetrating injury. There was an opening created from the outside into the pleural space. So that leads to filling up of air in the pleural space between parietal pleura and visceral pleura. As you must have discussed in your physiology lectures, or you will discuss that, the lungs are kept expanded by only suction. As the chest expand, the suction expand the lungs. But if you give that space air, the suction can no longer be maintained and the lung will collapse all the way to a very small part and they will become totally non-functional. So that's why the person will having breathing difficulty, his blood will not be oxygenated, you will need to somehow remove that air, and that's why you need to pass a needle or a tube. And this can occur without external injury also. For example, a person has a very severe lung disease and that lung disease leads to part of the lung rupturing into the pleural space, so the air from the lung will expand outside and the lung will collapse and the suction will end and the lung will collapse into a small non-functional mass of tissue. And even sometimes the tissue is bleed, it leaks the air like a valve, and that pressure that builds up a pressure in the pleural cavity. We will discuss this further in the when discussing pleura and thoracic wall, and that leads to tension pneumothorax. That pleura is at a very high tension, it's actually pushing the heart and the structure of mediastinum on the opposite side. So what do? We pass a needle, that is called thoracostomy. Whenever in a word you read ostomy, it means making an opening, getting an access, making an opening. So you can pass it through a needle thoracostomy. Ostomy means to make an opening, and otomy means to open up. Otomy means to open up. For example, you open up the thoracic wall, that is thoracotomy. If you insert something, you get a hole, you get a hole in that, you get needle thoracostomy, tube thoracostomy. So what are the places that are most commonly used for needle thoracostomy? These two you must have remember for your exam point of view and clinical practice point of view. These are very important. This space, second intercostal space, this is the first space, this is the second space, second intercostal space in the mid clavicular line. This is a very important point where you can safely insert a needle without uh, getting into the way of any major vessel, that is second intercostal space in the mid clavicular line. You will go through skin, superficial fascia, deep fascia, pec major, maybe pec minor, and external intercostal muscle, and internal, innermost, and so on. Though this is how you enter it. The second space that is approached usually for the tube insertion, that is through the mid axillary line or anterior axillary line. Both are fine answers. Mid, not mid clavicular line, mid axillary line or anterior axillary line in the fourth or fifth intercostal space. This is above the level of the liver, so you are safe. You won't penetrate the liver, you won't penetrate the diaphragm, you are above that level, and you can enter into the thorax to the tube, and it will go through the same layers. You will go through skin, two layers of superficial fascia, serratus anterior, then the three layers of muscles, external, middle, and internal, innermost, then uh, endothoracic fascia, and then pleura into the pleural space. So you must remember where the needle thoracostomy is done. It is done in second intercostal space into the midclavicular line. Where there is needle thoracostomy is done. Where is tube thoracostomy done? It is done in fourth intercostal space in midclavicular, mid axillary, or anterior axillary line. Anterior axillary line is preferred because it is the lateral cutaneous branches are exiting from the mid axillary line, so you save those by entering through the mid axillary line. Now the last point, the last piece of the puzzle is whether to enter from the superior aspect, upper aspect of the intercostal space, or the lower aspect of the intercostal space. The tube is inserted at the lower part. Why? Because if you had passed through superior aspect, there is a chance that you damage these intercostal artery, vein and nerve. Vein from most superiorly, nerve most inferiorly. Now you had asked the question that does the needle puncture affect collateral branches? Yes, when you pass through the lower aspect of the space, you damage the collateral branches, but the collateral branches are much smaller and inconspicuous. You do not do that much damage and you do not get that much functional loss. So that's why the lower part of the going through the lower part of the space is preferred, so that only collateral are damaged and you don't get that much damage, because the lateral cutaneous branches, anterior cutaneous branches, these are coming from the main branches. So you don't get a loss of a function, much loss of function from that. This particular question is asked you in multiple in a large number of ways. The question MCQs will ask which point needle thoracostomy is done, which point that is done, and then in this particular way, in you have to be very vigilant in the question stem. The tube is passed from superior part of the intercostal space or inferior part of the intercostal space. The answer will be the needle has to be passed from the inferior part of the intercostal space. Most of us are hardwired to give this answer, inferior, but the same question is asked, do I pass the needle or tube from the superior aspect of the rib or inferior aspect of the rib? Then your answer will be superior aspect of the rib rather than inferior aspect of the rib, because inferior aspect of the rib will damage the costal nerve. So be very vigilant regarding how the question is asked. Are you being asked regarding uh, which superior part of the space or inferior part of the space, or superior part of the nerve and inferior part of the nerve? So when passing a needle for needle thoracostomy, you have to go through inferior part of the space, or in other words, superior part of the rib. Now the similar question is asked regarding nerve block. If you have to do some surgery, you have to put up some stitch, you want that person to be anesthetized. So to anesthetize a person, you will insert a needle, and ideally you will insert a needle right here, and you will give some anesthetic solution so that this nerve will become anesthetized. So again, you have to be very vigilant regarding the stem. If for intercostal nerve block, you will have to pass the needle from the upper part of the space or lower part of the nerve, lower part of the rib. To avoid damage to the nerve, you have to enter from the upper part of the rib or lower part of the space. So this is very simple information, but it is posed in a number of ways, and students do get confused when they have memorized for a particular question. So that's about that. You have asked a question, first intercostal space is between first and second rib. Yes, you're totally right. The space is below the rib number. So that will be the first space, that will be the second space, that will be the third space. You will go all the way to have 11 spaces. You do not have the 12th space. Otherwise, you would have to start from space number 2 from the top, if you go the other way around. Thank you so much. That's all about the layers and the importance of layers when you are doing thoracotomy and thoracostomy. And